So I'd like to welcome Ann Mock, who is nice enough to come and present to us today on challenges for childhood cancer survivors. She works in the survivorship clinic at Shore and has been and you'll have to tell me how long you've been.
Oh, a long, long time. I started as a student in 94 and then I did a lot of clinicals with, I was with the School of Nursing, but I did a lot of clinicals with the Peds Hemont group because I knew that's what I wanted to do. And then I graduated with my BSN in 95 and or 94 and my master's in 95, and then worked for the School of Nursing in research until I could sit for my exam. And then I went out to the community for about 6 months before Dr. Russell called me and said, there's a position. Why don't you come and interview for it? So I got that and started in 1997. And it was ask funded. That's how I actually came down here. So 97 was the first time I actually was officially working with Peds Hemong, but I've been down in the VC system since 94, so I know a lot of patients from that era. So a long, long time.
That is a long time. And for those of you who don't know, the Shore Survivorship Clinic meets once a week, so every Monday.
That's right. Okay, so I'm going to share my screen, hopefully. We'll see if all this works. Oh, yeah, there it is. Oh my gosh, look at this.
Perfect.
Wait, now I just have to get to the start the show. Okay. All right, so what I'm going to talk about is an overview of survivorship from a pediatric perspective. And you guys feel free to interrupt me. I don't have very many slides. I only have 12 slides, but I really want to kind of keep it broad and a little, I mean, there's some specifics, but generally broad. And then at the end, you guys can ask me questions or we can talk about kind of where do we go from here. So there's good news in pediatric childhood cancer survivorship, and that is that today, almost 90% of children diagnosed with cancer are going to survive. And if you compare that looking back over the years, in 2008 to 2014, we were seeing, around a little more than 80% survival. When I was in high school, we were at just over 50% survival. And when I started here in 97, and I was actually working with the childhood cancer patients and their families and diagnosing the cancers, I would tell parents that the general survival statistics were at about 75%. So if you look at the numbers, I mean, this is a major medical breakthrough. It's a major medical accomplishment that pediatric childhood cancer needs to be really congratulated about because we're doing a great job of having children survive cancer. But there's bad news. And notwithstanding that 13% or so of children, we're not able to save their lives. But for those cancer survivors, 95% of them are going to have at least one chronic late effect by the time they're 45. And 80% of them are going to have at least one serious, disabling, or life-threatening chronic health condition. And that doesn't take to age 45 for these children to have this problem. So that could occur at any time along the spectrum. So really what we're saying is that these survivors are twice more likely than their peers or siblings to have a very difficult, let's say, transition to adulthood. They're going to have some serious medical problems. So what we know then is that cure is not enough. We know that cancer therapy can cause late effects, and the whole purpose of what we're trying to do is, figure out what are the risks for late effects and teach our patients about those things. So what are late effects? I mean, consequences of treatment that persist after therapy is ended. So late effects can actually be acute effects or acute side effects that just continue. They don't ever go away. a lot of times our patients that are diagnosed with cancer will have a side effect immediately to something that we're doing, to a drug or a transfusion or something. And when we pull that treatment away, the side effect goes away. But sometimes late effects are those acute effects that don't go away and they continue to bother the patient throughout the lifetime. Or late effects are consequences that occur after completion of therapy. And this could be at any point, again, along the spectrum. It could happen 1 month after therapy is ended. It could happen a year after therapy is ended. You could have this long honeymoon period where you're just doing great. And then suddenly, 10 years later down the road, you start to have some chronic health conditions. In general, we see late effects when there's a period of rapid growth. So if you think about a baby that has cancer and when they're going through puberty, that may be where you start to see some of these effects that we're going to talk about in a minute. And it's important to remember that every part of the body can be affected. There's not one part of your body that is not at risk for the development of late effects of childhood cancer. So let's talk a little bit about potential therapy-related complications or late effects. And we'll start with psychosocial or behavioral. Probably when I say that, you guys immediately think of anxiety or maybe depression or patients having, risky behaviors. Okay, they feel like they've survived childhood cancer, so maybe they think they can drink, they can smoke, they can drive around without a seatbelt without consequences. And that these are all true. We definitely do have patients with anxiety and depression, and we definitely do have, especially teens, who kind of feel like they're bigger than this whole idea of late effects. But you have to also think about other parts of the psychosocial or behavioral realm. And I'm talking about issues with insurance, especially when our young adults come off of their parents' insurance, if their parents have insurance. It's hard sometimes for them to get insurance. And then they really can't take care of themselves, or they're not going to be able to appropriately take care of themselves. Barriers to access to care, particularly for some of our patients who are getting care at VCU simply because they had cancer. And once the diagnosis of cancer is gone, and they may not have all of the opportunities for our care that they had previously, they might not be able to get care anywhere because they don't have insurance and they don't have a primary care and they just don't have those access points that most of us do have. We're talking about children who become young adults and they have a difficulty getting a job, maybe because of some of the late effects that they have, maybe a neurocognitive situation that they've got, but their access to the job market is different from their peers or even their siblings. Getting a driver's license is something that we use as a way to sort of gauge independence of some of our young adults or, kids who are teens and moving into young adulthood. Getting a driver's license is really a form of independence from your family, and it sort of shows us that you're wanting to maybe do some things that are less dependent on your family. But they have difficulty. A lot of our patients will have difficulty getting their driver's license. And then again, it's just that acquisition of independence. It's a transition for them from the cancer diagnosis to sort of the after the diagnosis, and it's a difficult period. So these are some of the things that we have to think about as far as psychosocial and behavioral. If you look at neurocognitive effects, it's a very broad range, and I mean, Alma can correct me, but I think almost all of our patients have some neurocognitive deficit after having had childhood cancer treatment. Now, if they're leukemia patients or they're brain tumor patients, they're going to have medication in the chemotherapy that crosses the blood-brain barrier. And that is because a brain tumor is obviously already in the central nervous system, but in leukemia and lymphoma, it can go to the central nervous system. So we have to prophylax against that happening. And so those patients are at high risk for neurocognitive deficit, simply because those treatments, whether it's chemotherapy or radiation, can end up changing your IQ by 10 to 15 IQ points, which is fine if you have an IQ of 140 and you're going down to 125. That's not really a problem. But if you're in the average range or even the low average range when you start treatment and your IQ is at 90 and you lose 15 points, you're now at 75, and that could really change how well you do in school and what vocational opportunities are there for you after school. Excuse me, I'm gonna have to just keep drinking because my mouth gets so dry. So when we think about neurocognitive effects, you have to think about what what your brain does. I mean, you think, you reason, you learn, you speak, you remember, you process information. And where we see the vast majority of the problems are in the executive functioning. So the planning, the organization, the short-term memory, the processing speed, how well children can problem solve, how they can manage their time. Are they impulsive? Can they meet deadlines? Excuse me, can they regulate their emotions? And what's their neuroflexibility? In other words, if they run into barriers or setbacks, do they have difficulty overcoming that, or are they able just to kind of cruise through it? And so these are all the areas where we generally will see problems in our patients who have neurocognitive deficits. As you know, we work closely with our psychosocial team, and we do try and get neuropsych testing on the patients who qualify. I mean, everyone really qualifies, but not everyone wants it. But we do try and do that so that we have a better understanding of how their brain is functioning and how they're learning. And then obviously we have Alma and Michelle and John, who are very, very involved in the school, how they're doing in school, and then vocationally, how they're doing after school and how we can help them get a job and be productive. When we talk about cardiovascular, and the big word cardiomyopathy just means anything that's a deficit related to your heart. So some of the common things that we might see would be blood pressure elevation. So someone might develop hypertension. Excuse me, dyslipidemia, where we would see higher cholesterol or LDL, lower HDL, or increased triglycerides, or actual heart failure. We have actually a fair number of young adults who have heart failure. Now, they're not going to tell you they have heart failure, but I'm going to tell you they have heart failure. And so their left ventricle is not working as well as it should, and they need to go on medication to help their heart pump more efficiently, because we really need to get them to live their whole life with their heart. If they don't have their heart, they're not going to be here. So pulmonary effects, we see pulmonary fibrosis and or obstructive lung disease. Now, the patients that are mostly at risk for this are patients who have had radiation to their chest for one reason or another. There are chemotherapeutic agents that can definitely cause pulmonary fibrosis or obstruction, and those are generally seen in our patients who have Hodgkin's lymphoma. But our Wilms tumor patients, generally, if they're stage 3 or 4, they're going to get whole lung radiation therapy. And honestly, we've lost one patient in her teens from obstructive lung disease who was a Wilms tumor survivor, and her lungs they were very stiff, and they didn't have the ability to actually expand and contract as you might need to breathe. And so we tried everything, and she just wasn't a good candidate for a lung transplant. We lost a second patient who had a lung transplant and then developed PTLD after her lung transplant, and she died. So while pulmonary fibrosis may not be the number one late effect, it can be very, very serious. If we talk about GI effects, One of the ones that immediately comes to mind is bowel obstruction. So anyone who has had any kind of radiation to their abdomen or pelvis, or had abdominal or pelvic surgery, is at risk for bowel obstruction. So again, if you think about a patient with a Wilms tumor, the surgeon generally makes a very large cut across the abdomen. So in a child that's 3 or 4, it goes like from basically from side to side, right around the belly button. And then that scar tissue can attach to other parts of the bowel, and eventually it can cause an obstruction. I have a patient who's a Wilms tumor survivor, and she's actually had a kidney transplant. She's had 3 small bowel obstructions. She's 22 years old. And 2 of her bowel obstructions were cleared with surgery, the most recent in January. And one of them, just symptomatic care and IV fluids, we were able to get around it. But as you can see, I mean, bowel obstruction can be a real problem. Um, Liver disease is something that most of our lymphoma and leukemia patients are at higher risk for because of some of the anti-metabolite therapy that we use. But I will say that for every patient who undergoes chemotherapy, all of the chemotherapy is cleared through the liver. So it makes sense that your liver would be one of the uh, one of the organs that you could actually have disease in. And then I will tell you that, 90% or 80 to 90% of patients will tell me that their gut took a very long time to recover and may actually never have recovered from chemotherapy. So I read an article that said that your GI system can take 10 years to recover from the effects of chemotherapy. Because if you think about it, we're giving chemotherapy, we're killing all the good cells, we're killing anything that's dividing. So good bacteria, skin cells, whatever. And think about your gut. You have a microbiome that you had before you got cancer, and then we completely destroy that. And God knows what is happening in your gut while you're getting your chemotherapy. But then you try and recover, and you've really got to get your bowel back to normal, and it's really hard to do that. And so a lot of our patients will complain of kind of diarrhea heavy or constipation heavy, irritable bowel syndrome complaints. And those are really embarrassing for people. It can help to go on a probiotic, but those are some of the things that patients talk about. Neurologic, the biggest things we see are peripheral neuropathy and Raynaud's. We definitely have patients who have had brain tumors with radiation, who have had seizures, and I'm not minimizing that at all, but that's a pretty small number, at least at this stage. But peripheral neuropathy and Raynaud's can be a side effect of vincristine. And almost every patient, whether it's a liquid tumor or a solid tumor, is going to get vincristine. So a lot of patients will say they can feel numbness or tingling in their fingertips or the bottoms of their feet. And those, they feel that when there's a change in atmospheric pressure, for example, if there's a low pressure system moving through, they might feel, oh gosh, my fingers or my feet felt like when I was getting my vincristine. Patients have told me that for some reason, pinky fingers and pinky toes seem to get numb more frequently than their other fingers. So it's definitely individualized, and not everyone has those symptoms. Raynaud's is just simply colder hands and feet as compared to the central part of your body. So for some people, it can be very painful. You might only have it in one digit, like your pointer finger, but it'll turn blue or be painful when the weather is cold. So that's sort of neurologic. If we look at subsequent malignant neoplasms, this one is really hard because you celebrate when they finish treatment, and then they come over to our clinic and we give them a little.
You just lost sound, Anne. Can you hear me? she's going to get some help.
Now
Nope.
what? Just take this out.
Can you guys hear us?
Yes, we can hear you.
Wow.
That's what it was tapping.
I don't know what happened. So what do I have to do with that?
There's no way to dismantle it
Oh.
on this computer.
Yippee. Okay, y'all. It may happen again, so you'll just have to bear with me. I'll have to sign back in or something. Okay, so we were talking about the subsequent malignant neoplasms. And so it's really hard to talk to a family once they've celebrated getting off of treatment that they're at risk for secondary malignancies. And those generally, the ones that are related to the chemotherapeutic agents are AML and MDS, which is myelodysplastic syndrome. And those are from certain chemotherapeutic agents that make changes in your chromosomes and that are associated with AML or MDS. The skin, the breast, the colon, and the brain cancers are really more of a side effect of radiation because radiation changes DNA in cells. And so that cells that don't have adequate DNA cannot divide, and that is how you kill a cancer cell. But it also creates free radicals, and those free radicals over time can accumulate and cause secondary cancers. So the skin, the breast, the colon, lung, brain cancers, those are all secondary malignancies from radiation, or as in the situation with lung cancers or liver cancers, it could be from smoking or from alcoholism or heavy drinking. But the good news is I heard a talk on Tuesday on proton beam radiation, and it does appear that that is going to really bring down the numbers of late effects for malignant neoplasms from radiation if we could all be using proton beam radiation, because it really doesn't have an exit dose. I mean, it doesn't have an exit. It doesn't exit the body. It stays in, and it can be defined to a much smaller problem. There's no real scatter with it. The problem with it is it's very, very expensive. And so very few centers have it, but something to think about for the future. Other complications, it's not letting me go forward. Okay. Auditory. So we can have hearing loss or tinnitus, however you want to pronounce it. We get high frequency hearing loss from platinum agents, which are chemotherapeutic agents, or from radiation to the head or face. The hearing loss can be bilateral or just one ear. A lot of patients are needing hearing aids, and the numbers of patients that actually wear their hearing aids is not as much as we would like. So we need to do a little better with that. But I will say that having a hearing loss can be a very isolating situation. One patient in particular who's actually got cochlear implants, she has a really hard time hearing in an environment where there's background noise. So whether it's coming to a group session at Ask or going to a restaurant, she cannot discern noise, and she can't make any sense out of it because she's always hearing the background noise. And she doesn't read lips very well. So it's very, very isolating for her. And I feel really badly for her. So it would be great if we could come up with a way to avoid the hearing loss altogether. Dental, especially for children under 5 who are treated, you can have missing roots, missing teeth, no permanent teeth, for example. You can have gum disease. You can have lack of enamel on your teeth, so increased cavity risk. There's so many ways that we can affect your teeth, especially if you're young, because if you think about it, remember that chemotherapy, it's attacking those rapidly dividing cells. And when you're a baby, your teeth are forming, they're just way up in your bone. But if the rapidly dividing cells are your teeth cells, then you won't have teeth when you need them. Dermatologic side effects, we can see fibrosis, altered pigmentation, especially in our darker colored darker colored kids or teens. They generally will have, if they have discoloration and it's dark to begin with, on dark skin, it tends not to fade as well as it would on lighter colored skin. So that can be something that is a problem, especially if it's on a face of a female patient. Children with leukemia have increased mole development after leukemia, and then we can see a increased risk for skin cancer. And I just want to tell you, one of our long-term survivors regarding fibrosis, she had Ewing's and she had radiation to her pelvis. And one side of her, if you look at her from the back, one side of her bottom is very different from the other side. And she works out all the time, and she's always told me she's had a hard time stretching the side that had the radiation. But the other day she was running in her kitchen, chasing her cat. And honestly, she leaped for her cat and she tore her hamstring. And I've seen the MRI, and I mean, the tear is like a 2-inch tear in the muscle itself. So she's going to need to have surgery to repair that. So when I'm talking about fibrosis, I'm talking about fibrosis of skin, muscle, whatever is there. You can't really fibrose a bone, but it's a problem. So for eyes, we can have early cataracts, children that have had leukemia treatment or brain tumors, anyone that's had steroids for any length of time or radiation to the head is at risk for early cataracts. We've definitely done a better job with changing the way we dose and give our steroids to avoid early cataracts, but with radiation, if their eye is in the field, it's definitely a possibility. And then optic nerve injury can also occur from radiation from surgery to the head, or if you have a glioma, your optic nerve is likely going to be involved to begin with. Urinary tract. So this is kind of a one that you might not even think about. But we have a large number of patients who have renal insufficiency or they have bladder issues. And bladder issues can be some like you don't have the reserve. You're always feeling like you have to go to the bathroom. And so you're frequently going to the bathroom, or you don't get the warning that your bladder is full. And so you're just sitting there and suddenly you have 2 seconds to make it to the bathroom and actually empty your bladder, or it's going to empty itself. And so things like that, the bladder, if it's in the radiation field, can definitely undergo fibrosis, and that means it doesn't stretch and release like it should. So that kind of leads to those accident-prone situations. Some of the alkylators will affect how your bladder works. And so the urinary tract, I always really ask every patient a lot of voiding questions. Musculoskeletal, so reduced bone mineral density for patients who have had any kind of steroids. They often will have a low vitamin D, and vitamin D is really essential for good bone health. So the steroids and the low vitamin D can result in reduced bone mineral density. You don't want to be osteopenic when you're 20 or in your teens or even in your 30s. So we really try and stay on top of that. And then you have to think of our patients that have had osteosarcoma, which is a bone cancer, or Ewing sarcoma, which is bone or soft tissue sarcoma. They might have had an amputation or maybe a limb salvage. And you have to think about, if it's an amputated limb, they're going to have a stump, which is going to need stump care. They may or may not decide to go with a prosthesis, But as they grow, that prosthesis is going to need to be changed because their body's going to change. And, it's going to be a lifelong care for that patient. Every 2 years or so, they're probably going to need some kind of a tweak of something. For limb salvage, it may be a little more intense because if they're a growing child, when they have their limb salvage, again, the surgeon's going to put in a piece of hardware that's likely going to grow with them, but there's always hardware failures. And at some point, they're going to need, serial surgeries as they grow for that hardware to grow with them. You can't get from 10 to 18 generally with one surgery. There's going to be multiple surgeries in there. Reproductive is a place where we're making a lot of strides, but we're still having patients, unfortunately, who are infertile. So you can have gonadal dysfunction where the brain and the end organ, whatever it is, if it's an ovary or a testicle, isn't communicating well. And so you might have an ovarian failure situation, or you might have a situation where the testosterone isn't enough for the male to feel male. Or we can have overt infertility, or for females, you can have early menopause. So we do ask frequently for males, if they are 15 or older, I think, we will ask them to bank their sperm before we start treatment so that we will have some sperm that's available to them later if their treatment is going to put them at risk for infertility. But if you're prepubertal, or if you just aren't able to give that sample, we don't really have anything for you. So unfortunately, that's sort of not a great thing. For females, we're trying hard and we're working hard to come up with ways to preserve their fertility. And we can do that with some drugs, but we haven't really been able to we've taken some parts of people's ovaries, and you can put them somewhere on their body. And then when they're done with their treatment, you can hopefully reinstate it and it will work. But it hadn't really worked that well. So a lot of females are now, when treatment is over, they're going to our friends at Reproductive Endocrinology and going through egg retrieval so that we can actually store and deep freeze these eggs. They're not fertilized, and when they're ready, when they're older and they're ready to use them, they can be available for them. So that is one way that we're helping there. And we definitely didn't have that when I first started. Endocrine and metabolic. So luckily for us, we work in the endocrine clinic. So we work really closely with Dr. Hensley. And we are able, I think, to capture a large number of patients who previously weren't captured. But obesity and diabetes, or even just not overt diabetes, but higher blood sugar, growth issues, those are some of the things that we see. Any child who's had a brain tumor and had radiation to his head is at risk for multiple endocrinopathies over their lifetime. And generally speaking, it could be thyroid disease. They're going to have them, and they're going to be seeing an endocrine specialist for their lifetime. And then we have the patients who will have immune deficiencies. Now, I'll say that a lot of patients with leukemia and lymphoma, we're targeting the bone marrow because that's where the bone marrow for leukemia, for lymphoma, it's their lymph system, but that's where the disease is. And a lot of times those patients will have lower than average numbers of white count, or maybe hemoglobin, or maybe platelets. And you just learn that that's where they live. If someone other than one of us were to see them, they might be like, oh my gosh, this child is neutropenic. And that would frighten them. But we've kind of figured out over time, well, this is where they live and they don't get infections. It's okay. But we can see patients who are neutropenic and will get an infection once they're off treatment. And that's just kind of how it is. Their white count is low. They don't make the sufficient number of neutrophils, and they're more at risk for bacterial infections. We can have patients who are functionally hyposplenic, which the spleen really helps. It's a big part of your immune system, and if it's not working well, that can certainly affect you. And then definitely our patients who have been transplanted or who have CAR T cell. The CAR T cell patients, which is a small subset, those guys are on immunoglobulin, which is a every 2 to 3 week infusion subcutaneously for lifetime. We have messed with their T cells and their B cells, and those are two important parts of your immune system. And they actually need to have an infusion in order to keep from getting infections. At least that's the state of the science today. Okay, so after all that, let's talk about some more good news. We've figured out that we can impact the risk for late effects and modify that through early detection and risk management. And that's really why we have our survivorship clinic. So if we have lifestyle modifications, we can reduce the risk for late effects. And so, we will talk about that, I guess, on the next slide. Okay. We use the Children's Oncology Group long-term follow-up guidelines for survivors of childhood, adolescent, and young adult cancers. This is the website where you can actually find those guidelines. They were updated in October of 2023, and they actually came out to all of us in December of 2023. This is a 391-page document if you want to include the health links, which are important sort of additives. They are printed in English, Spanish, and some of them are in French. We need them in more languages, but we're doing a good job so far. There are 211 pages of actual guidelines that Dr. Gauda and I use when we're looking at each individual child, their childhood cancer treatment, and then we basically cross-reference what they got with what the guidelines tell us. And there's an appendix that adds another, 40 pages. But that's really important for us because it helps us. It explains like radiation fields and all kinds of things that are really cool. It'd be great for primary care and other physicians as well. And really interesting for you guys if you want to look at it. But what these are risk-based, evidence-based, exposure-related guidelines for screening and management of late effects. And so when we say evidence-based, a group of us some 20 years ago got together, and I was one of the lucky ones to be involved with this, and we looked at research, and we're still doing it. And we looked at research on what we knew had happened from a cohort of patients that were treated from 1975, and now we're all the way up to like 2012, I think. Where these kids are getting older and we're looking at what their late effects are and what their treatment was. And then we're making some, conclusions about that and doing research on it to see, is this really what is causing this late effect? And so it's been a great thing. We are actually tailoring our late effects based on the evidence, based on the research. And then we're able to tailor the guidelines to actually tell us how can we get you from the end of your treatment to adulthood. So it's a really good thing. We're on version 6 right now. So in our childhood cancer survivorship clinic here, there's 4 prongs really to what we do. The first thing, and really I think the main thing, is educate. We educate patients and families. I mean, we are patient family centered, and we want to educate them about the treatment they had, what their risks are, and then we want to help them navigate whatever the plan of care is for that. How we're going to get the surveillance you need, the specialists that you need to see, and how we can help you manage your life moving forward. The second thing we are looking at is health maintenance. So we want to meet our patients, and we definitely want them to want to do better. Let me see. I should have said something more about education. So let me go back for a second. Madhu and I are talking to them at the clinic about the surveillance. Alma, John, and Michelle and Kim also are in there talking to them about the other parts of education that are so important, such as how they're doing in school, what's going on in their job, do they have a job, are they going to get a job, how can we help you there? So we're in touch with them really at the clinic base, and that's sort of the first pass. But once people have digested sort of what you've told them, they tend to talk about it more. Like I'll get a phone call, it could be 3 months later, where someone will call me and say, hey, I've really been thinking about it and this is what I want to do. Or I think I want to lose some weight, or I think I want to do this, or I think I want to do that. When you guys have the ask retreats or all those events that you have for our childhood cancer survivors, those are another opportunities for them to meet with their peers and talk about it and share their experience. And so educate is really like the biggest thing I think that we do. Okay, health maintenance. So we want to health maintenance. We want to establish a routine for health maintenance. I want every one of my patients to have a primary care physician, as does Dr. Gouda. And not everyone does. And so a lot of times they kind of think, well, we're it, but we're not it. So we want to get the primary care physician involved. We want to get a dentist involved if they don't have one, an eye doctor if they need that, someone to help with their hearing if that's what it is. And we want to just establish a group of specialists, if you will, or generalists to make sure that their health is going to be maintained based on our survivorship guidelines. And then for health promotion, we want to promote healthy lifestyles. We have a large number of patients who are overweight. And so I will want to be able to refer them to a nutritionist or help them work on some sort of, I don't want to use the word diet, but some lifestyle change that they begin to realize that maybe the way they're eating is not helping them, and there's a better way to approach that. I want my patients to exercise, and I'm specific as to how much. And so gym memberships are important. If they can't afford it, it'd be great if they could, or if they could just do it at home. But we want them to incorporate exercise into their general routine. And then avoiding carcinogens. I'm always saying, smoking is not good for you. Vaping is not good for you. Binge drinking is not good for you. There's all kinds of ways that as you age, you develop these habits that are bad and that can lead to cancer. And it's not a good idea if you've already had cancer to ask another cancer to come on board. And then the second thing I think that is really important that we do that I think we do a really good job of is advocacy and empowerment. Because honestly, we've got to create or help support these children and young adults to live an empowered life. And I think we need to get them to take the reins, to be able to understand their weaknesses, celebrate their strengths, and then go ahead and do the surveillance, not on their own, but take it all in and be empowered to take it and run with it. We want our patients to be successful, whatever that means to them. And I am not saying it's what I think is successful. It's what they think is successful. We're going to help them get there. We want them to be a good citizen. We want them to respect themselves and others. We want them to be a good neighbor. And we want to increase their self-esteem to make them feel good about themselves no matter where they are in their trajectory. We want them to feel good about themselves, their body, and their path. And lastly, we want to encourage them to give back because honestly, I think in giving back, you come full circle and you really can sort of feel good about everything that's happened to you when you're giving back to others. But we need to do some work. We need to do some work. And here's the work that we need to do. There are still huge barriers to care. We have a large number of patients who are lost to follow-up. I will say we're above the national average, and we keep a good deal more than 40% of our patients. But I'm sad about the percentage that we've lost. Even if we're at 50 or 60%, there's a huge number that we're not getting. And I don't know, I don't know if I knew well, I know who they are, but if they would tell me why they're not coming, maybe we could fix that. Insurance is one problem that we definitely have. There just isn't good insurance for long-term survivors. There's access issues. There are access issues for multiple reasons. Maybe they don't perceive that they have a risk. Maybe they don't have the money. Maybe they don't have the insurance. Maybe they don't have the language. Maybe it's a language barrier situation. Maybe it's a cultural barrier. Maybe they don't have a treatment summary, so they don't even know. Like when they left, they were celebrating their disease free, but they don't even know what's ahead for them. And as I told you kind of earlier, I think I mentioned this, transitions for our patient population, it's difficult. So the transition from pediatric to adult is problematic. It's problematic for me because all of my resources really are mostly pediatric. I'm developing resources in the adult world because I have a lot of patients who are older than 21, but there's no survivorship clinic. It's me and Madhu seeing patients into, I don't even want to tell you, 40s and low 50s, because there's no mechanism. And this is not just us, this is an international problem. There's no mechanism for transitioning them to adulthood. So that's something that we need to really look at. And then more research is needed. Yes, we're doing research all the time, but we really need to spend some dollars on understanding late effects and how we can change our protocols to avoid the late effects that we have, but still cure cancer. And then finally, improve the access to education, insurance, and employment for childhood cancer survivors. I know one of our survivors was recently let go from his job that he had had for quite some time. And I'm sure he derived a great deal of self-esteem from having his job. And I'm sure, well, I'm not sure, I have no idea, but I'm thinking that they probably filled his position with a, young 14 or 15 or 16 or 17-year-old who didn't really know that they had just taken the job of a, childhood cancer survivor. And I don't know, I feel like we have got to have avenues for our survivors to get employed so that they can feel productive and give back to society. And then this is just, oh, hold on. Okay, ideas or wish list for ask. So, young adult support assistance. We had sort of talked about this Monday in clinic when I was there, but some things that maybe we could think about doing, monies to support extras. And like some of our patients who have adult failure to thrive and are on very low incomes really can't afford the dietary supplements. I'm talking like $250 for a 3-month supply of nutritional supplements, but they simply can't afford that. Some of our patients with vitamin D deficiencies can't afford the vitamin supplements. And I mean, I don't know what to do. I mean, I don't know what to do about that. But if there could be a pot of money that could be, ask could look at it and decide how to spend it. But there for like special situations in some of our young adults, I think that would be great. I would love it if we could provide Fitbits for patients who live in rural areas who don't have access to a gym, or who live on a highway in a rural area and they can walk around their yard, but they can't go out and walk the street because they don't live in a neighborhood, they're on a highway. And so if they had a Fitbit, I could work with them to like target how many, steps they were going to get a day, or what's their sleep like, or what we could do about calories. I mean, there's just lots of ways to sort of think about that. And then another idea would be to partnership with local gyms like Crunch and Gold's Gym, who generally tend to run these super, super cheap, joining fees at certain times of the year. Like at the beginning of the year, it's like $1 a month or something. where, you guys could figure out, or we could figure out together how often or how long you wanted to run, maybe do it for 6 months, see how they do at a reduced cost. And then slowly, once they kind of get into it, let them start taking over, if they can, more of the cost. But those are just some of the things that I see that maybe we could do for some of our patients in the survivorship clinic. Okay, so I'm just going to close, and I talked for a lot longer than I thought I would. I'm sorry about that. Life is a hollow gift unless cancer survivors emerge from treatment as competent and worthy individuals, able to obtain insurance, equipped to earn a living, and prepared to participate in a medical surveillance program to keep the life they have won. And that is from Grace Powers Monaco, who is a childhood cancer advocate, supreme. And I really believe this. I think that we have to really help them get to the point where they can help themselves. So that's all I have. You guys can ask me questions or whatever you want to do at this point.
Thanks, Ian. Yeah, we'll open the floor up for questions. I have to say, of all our topics we've had, I was like, oh, I feel like I have a good grasp of survivorship issues, but you have proved me wrong. I learned a lot. So thank you.
You're welcome.
Does anybody have any questions for Ian?
Hey, Ann.
Alma.
Ann,
Yeah.
that's one of your best talks yet. Good one.
Thank you.
Keep that one. Kudos.
Okay. Oh, thank you.
Yeah, I don't have any questions, but thank you, Anne.
Oh,
I
you're
appreciate
welcome.
it.
Yeah, absolutely.